Hello and welcome to today's webinar. Good afternoon to you if you're coming in from the west, and a good evening if you're out on the east. I understand there's snow all over. My name is Eddy Lang, and I'm the head of emergency medicine in Calgary at the Cummings School of Medicine and with Alberta Health Services. And on behalf of CAEP, I am delighted to be your moderator this evening for what I hope will be, and I'm sure will be, a really fun and interesting session. A little bit of background. Our webinar topic has been independently conceived by our scientific planning committee, which I chair. It has Stacy Kitts on it, Kirat Grewal, and Rob Stenstrom. My disclosures are here, all honorarium from CAEP webinars that are industry sponsored or redirected to I redirect to the CAEP Research Fund or to the Calgary Health Foundation. And this particular program did receive support from Novo Nordisk. None of the other members of the planning committee have relevant conflicts of interest to declare. And we did not receive any direct funding, neither I or Dr. Rydz, from the organization, from the company that is the sponsor. We have made all best efforts to reduce any potential biases, and there's a question in the evaluation that addresses this. But we have completely complied with the accreditation standards and have done what is necessary to mitigate that bias. So let me give you a little bit of more background on today's webinar. The committee settled on this topic in early 2021. We've heard through needs assessments that this is an area that can be a little bit tricky and a little confusing, and emergency providers from all over Canada thought it would be an important area to address. We had our first session with Adrian Lee, who talked about this, and now really excited to welcome Dr. Natalia Ridz, that you'll hear more about in a moment. So when we talk about unexplained bleeding, and you can scan through these learning objectives as we move on in this presentation, we're really trying to identify those situations where you're going to have bleeding that wouldn't be explained by trauma or by patients who are on anticoagulants. We also want to give you the practical tools that you need to investigate these patients, manage the bleeding situation based on urgency, know what tools are in your armamentarium, both from a diagnostic and a differential diagnostic perspective, and if you're involving the hematologist, to know how to leverage that connection optimally. We're also going to hear a little bit about care plans and other really cool tools that you will have at your disposal when meeting and caring for a patient with unexplained bleeding, and hence the name of our talk. So just to tell you a little bit more, we always like to keep these as interactive as possible. Most of you would be familiar, if you've been part of these webinar series, with the menti.com. We've got the QR code there for you to scan, and we'll make the code available right there or in the chat window for you to look at. There's going to be some interesting multiple choice questions, and we're going to use this to really get a sense of what is happening in terms of management for these conditions across the country. And now it's really my pleasure to introduce your speaker for this evening and afternoon. It's Dr. Natalia Ridz, who I've known for years. So I'm very lucky to have her as a colleague here at the Foothills Medical Center in Calgary. She is specialized in benign hematology. She's a clinical associate professor in the Division of Hematology and Hematology Malignancies here at the U of C. She did her training at UBC in a hemostasis fellowship at Queen's University in Kingston. She's the medical director of the Southern Alberta Rare Blood and Bleeding Comprehensive Care Program that you're going to hear more about. This program provides comprehensive resources and advice and care pathways for patients with both congenital and acquired bleeding disorders, as well as hemoglobinopathies like sickle cell in multidisciplinary settings. Her research interests include congenital bleeding disorders and quality improvement in the management of sickle cell disease. So without further ado, over to you, Dr. Ridz.
Wonderful, and I'm just going to share my slides, just one moment here. So thank you very much for that introduction, Dr. Lang. As mentioned, we'll be speaking about the bleeding patient in the emergency department. So I have no conflicts of interest with respect to this particular talk. I do have some grants from Novo Nordisk for an investigator-initiated study in sickle cell disease, and sit on the advisory board for some pharmaceutical companies. But again, nothing that would be a conflict of interest here. I do want to state that one of my conflicts of interest, it's kind of informal, is actually I have a sister who's an emergency physician, and Dr. Lang will know her from her training days. And the reason why it's a conflict of interest is I think it makes my threshold for saying, just call me, just call a hematologist quite low, because I always encourage her just to call me. So I know kind of the emergency room perspective from her point of view. Sorry, let me just. So again, disclosure of financial support, no direct support from Novo Nordisk for this educational opportunity here. And Dr. Lang has already gone over the maneuvers for mitigating potential bias, so I won't review them again. And really today, what I was hoping to do with you is to go through a few different cases outlining the approach to bleeding disorders, really trying to emphasize some resources that may be available to you as emergency physicians. And again, trying to emphasize the thresholds that you guys should have for calling out for help, either from the transfusion medicine physicians at your centers or from the hematologists. So the first patient I'm going to discuss today is Andrea. Andrea is a 20-year-old woman with a history of post-infectious GN, diagnosed in 2010, and ADHD. Her only medication is dextrodin, 10 milligrams daily, and she has no personal or family history of bleeding disorders. Andrea presented in late November of 2020 with spontaneous bruising. In December, she had some routine blood work and presented to her family physician with extensive ecchymosis in the site of the venipuncture. She then presented a month later to the emergency department with a spontaneous pain, swelling, and bruising in her right calf. The D-dimer was elevated, her INR was 1.0, and her CBC was normal. She had an ultrasound that was negative for DVT, but did show mild subcutaneous edema. She was discharged to follow up with her family physician. Before I go on, so a polling question now, and we'll pause for that. Andrea returned to the emergency department several days later with more extensive bruising to the right leg. At this point, what would you do as far as investigations? A, repeat the INR. B, order an INR and PTT. C, order an INR, PTT, and CBC. D, order an INR, PTT, fibrinogen, CBC, renal, and liver panel. And I'll just give you a few seconds to start answering. Wonderful. So I agree, and I'll admit, as a hematologist, I probably have a very low threshold to order a lot of blood work. But this is a 20-year-old coming in with a new symptom of bleeding that's unexplained and in fact progressing. So I think it makes sense to look at a basic liver and renal panel. You're starting to think, is this acquired? Is this DIC? What else is going on? And so a more extensive blood work panel makes sense in this situation. Thank you for your answers. So again, D is what I would have done in that situation. And what you see is that her CBC is normal. Her fibrinogen and renal and liver panels are also normal. Her PT, her INR, that is, continues to be 1.0, so within the normal range. But her PTT is quite prolonged at 91.8 seconds, and the upper limit of normal at our local hospital is 38.0 seconds. So again, pausing here, do you feel confident in working up a prolonged PTT? And if you could please rate your comfort on a scale of 1 to 5, 1 being very uncomfortable and 5 being very comfortable. And I'll just give it a few more seconds before going to the next slide. Great, so a bit of a range, but mostly kind of in the area of uncomfortable, and I think that makes sense. That's why you're here today. And I do have to say that I think we've done the medical community a huge disservice by having that complicated coagulation cascade, and that really turns off most people as far as kind of understanding and liking PTT and PT assays and working them up. Perfect. So we will go over the workup of a prolonged PTT. When you have a prolonged PTT, the first test that we usually order is a mixing study. And the reason for that is the main differentiating point at the onset is to try to determine whether this patient has a deficiency in one of the factors that makes up the PTT or an inhibitor. And so a mixing study very simply is just taking an aliquot of patient plasma and mixing it in a 1-to-1 ratio with control plasma. And then you run the PTT again. The reason why we do this is, in theory, if the normal plasma has 100% factor in it and you mix it with something that is deficient, the aliquot or the mixture that you have should still have about 50% of the factors. And 50% is enough to have a normal PTT. Our PTT reagents usually don't start to pick up deficiencies until you're well below 50. So in the context of a deficiency, a mixing study should still show a normal PTT when repeated on the mixed specimen. In contrast to that, if you have an inhibitor, it doesn't matter how much factor you have in your normal plasma aliquot. What will happen is that inhibitor, that antibody that's present in patient plasma, will react with the factor levels that are in your normal or control plasma and will inhibit them as well. So in a mixing study with an inhibitor patient, what you have is a PTT that remains prolonged on the mixed sample. And so that's the first point of differentiation. You do the mixing study. If it corrects, you have a deficiency. If it is prolonged, you probably have an inhibitor. Now, with that information, you want to work up this patient further. So if it corrects, again, you probably have an inhibitor, and you have an inhibitor in that intrinsic pathway, in the pathway that the PTT is particularly set up to monitor and to evaluate. So the factor levels that are part of the PTT pathway are factor 12, factor 11, factor 9, and factor 12. And these are the factors that you would look for. You'd look for a deficiency in these factors. Now, clinically, what's interesting is that factor 12, although when deficient causes a prolonged PTT, it doesn't actually lead to a bleeding disorder. So it's one of those things that's important in the assay, but biologically in vivo is not as important for actual hemostasis. So in a bleeding patient with a prolonged PTT, if you're looking for a factor deficiency, you're more likely thinking that they have a factor 8, 9, or 11 deficiency. If your PTT does not correct, meaning that they have an inhibitor, this could either be iatrogenic, so medications certainly can inhibit different parts of the coagulation cascade, and those medications are obviously the anticoagulants, so heparin, direct thrombin inhibitors, or the direct anti-10A inhibitors. So you have to go back to the patient and just very carefully evaluate whether they're perhaps on one of these medications. The places where you can have a prolonged PTT and it may not be obvious is if someone has a line and it's heparin locked. Therefore, you're picking up a prolonged PTT if it wasn't flushed appropriately when that blood was taken, but perhaps the patient isn't overall anticoagulated. So being very careful about any exposure to medications, and in particular, looking to see where that blood was taken from and it's not, a heparin impregnated line, for example. If it's not a drug effect, then you're thinking about antibodies. And what kind of antibodies can you have that prolong the PTT? Well, you can have antibodies that are specifically targeted to particular factors. And the most common is actually an antibody against factor 8, which we call acquired hemophilia A. On the other hand, you can also have non-specific antibodies. So these are antibodies that probably bind to different parts of phospholipid membranes, which are important in coagulation, and in particular important in the PTT assay. So these non-specific antibodies can prolong your PTT, but in vivo, these antibodies, these lupus anticoagulants, are actually not associated with bleeding. And in fact, in the context of antiphospholipid syndrome, are associated with increased risk of thrombosis. So these are those non-specific antibodies that you can see. So after you do the mixing study, you go on to do factor levels. So you would do factor 8, depending on where you are in the country and what your laboratory setup is. Either you have to individually order these factor levels, Or your laboratory, for example, here, the special coagulation laboratory, if you simply say work up prolonged PTT, they will go through this pathway and actually order everything for you and do it for you until they come to an answer as far as the explanation for the prolonged PTT. But if you do have to order it yourself, you're ordering a factor 8, 9, and potentially 11. Now, there are certain circumstances where you don't need to order these factor levels, and that is if you have a prolonged PTT, the patient isn't bleeding, and your laboratory has been able to do a lupus anticoagulant and shows that it's positive. So in that case, you probably have this non-specific inhibitor. The patient doesn't clinically have any bleeding, and that is enough of a diagnosis right there to call it a lupus anticoagulant. So the patient has gone through this algorithm, and we've done these different tests. As mentioned, her APTT is prolonged 92 seconds. The control sample that it was mixed with had a PTT that was 25 seconds. And when you did a one-to-one mix and repeated this PTT, it was still prolonged at 90 seconds, which means that we're suspecting there's an inhibitor here. The fact that she has a prolonged PTT, a non-correcting mixing study, and is presenting clinically with bleeding really makes us think that she has an inhibitor against a particular factor. And in this case, her factor 8 level came back at 1%. Now, normal for most factor levels is between 50 and 150%, so this is significantly decreased. Our lab went on to do an inhibitor assay, and we found that she had a markedly elevated inhibitor of 79 Bethesda units. Normal would be 0. Less than 5 is considered to be a mild or a low titer inhibitor, and anything above 5 is a high titer inhibitor. So again, this patient has acquired hemophilia A, and I thought it'd be useful to know from the audience, how many acquired hemophilia patients have you seen in the emergency department, whether it's already diagnosed and they've come in with bleeding, or whether it's a new diagnosis that you've made. A, I've never seen one. B, I've seen one in my career. C, maybe 2 to 5. D, 6 to 10, or E, more than 10. It's actually lower than I thought it'd be. It's funny how when you're a hammer, everything's a nail. In any case, so these are rare patients, and we're going to get into that right away. So I'm glad that we're having this discussion just to raise awareness around them. Next question is, what is your threshold for calling hematology? Would you call hematology when you're seeing this patient 3 days later and they have this bleeding and you're thinking, well, this is not normal, I want hematology to help me now? Would you call them when you see the abnormal PTT, when the mixing study fails to correct, when acquired hemophilia is confirmed, or finally, before you actually go ahead and try to treat the patient with blood products? I'll just give it another minute or so. Great. So I'm happy to see that there's a relatively low threshold for calling hematology. What I would want to say is obviously there's no right or wrong answer. It depends on the patient's clinical presentation, how severely they're bleeding or if they're bleeding, and exactly what their comorbidities are, etc. I think the real point of this question was to state that as hematologists, we are very used to receiving these phone calls about abnormal bleeding and the spectrum of abnormal bleeding. And so it would not make me think twice to actually be called at any one of these points, which means that I think really as emergency physicians who are, as emergency physicians who are not seeing abnormal bleeding, acquired hemophilia, or these rare bleeding diagnoses very often, it would be very appropriate to have a low threshold to give us a call. moving on further, just to give you an idea, so hemophilia treatment centers who specialize in both acquired and congenital bleeding disorders, there's about 1 to 2 hemophilia treatment centers in most provinces, with several more in Quebec and Ontario. These are centers that are made up of usually a multidisciplinary team, but in particular, most of them have a couple of hematologists who specifically have been trained and think a lot about bleeding disorders. All of the hemophilia treatment centers are actually referral centers for acquired bleeding as well. And we tend to try to accumulate these patients because they really do have, they're rare and they really do require a subspecialty level of knowledge for appropriate treatment. In Alberta, we have 2 hemophilia treatment centers. Our center here in Calgary actually covers everything from Red Deer and south. And so we, in a year, probably see anywhere from 3 to 5 acquired hemophilias per year, and we would accept them from any part of the southern part of the province. Wherever you are in Canada, you will have a hemophilia treatment center that whose catchment area you belong to. And I can tell you it's a very small community of really motivated hematologists. I don't think any one of them would ever blink twice if you were to reach out to them if you had a case of acquired hemophilia or a bleeding disorder case that you needed help with. So acquired hemophilia A is a bleeding disorder caused by an autoantibody to factor VIII. The estimated incidence is 1.5 million per year, and it mainly affects older adults, but there's this bimodal distribution that's usually associated with pregnancy. So we usually see it in kind of 70, 80-year-olds, but there's another peak in the 20s, 30s, and it's usually associated with pregnancy or postpartum, kind of the immune dysregulation that happens in that context. So this patient I'm presenting is actually quite unusual to be 20 years old, and not pregnant, not postpartum, present with acquired hemophilia. I think it's the youngest case we have that hasn't been pregnancy associated. Acquired hemophilia can also occur secondary to a number of other associated conditions, such as autoimmune disease, malignancy, drug-induced, or skin conditions. The bleeding can really range from life-threatening to mild. And the thing to also remember is that often patients can be minimally symptomatic until they present to medical attention and require some kind of intervention. So if the PTT is not recognized and they go for surgery, if they have venipuncture, if they have a line placed, that's when we can really see significant bleeding complications. These patients have no personal or family history of bleeding. If you have electronic medical records that go back a ways, you'll often find that they previously had normal PTTs, and this is the first time they're presenting with a prolonged PTT. The mortality rate with acquired hemophilia is estimated to be quite high, and that's because it's under-recognized and these patients tend to have significant bleeding complications. So depending on where you read, the estimates are anywhere between 8 to 22%. The bleeding phenotype is different from congenital hemophilia. When you have a congenital hemophilia or factor VIII deficiency, those patients tend to bleed into their muscles or joints. In contrast to that, acquired hemophilia for some reason tends to be more of a mucocutaneous bleeding phenotype. They can present with GI or GU bleeding, but often with extensive soft tissue ecchymoses. These are just some classic pictures of patients with acquired hemophilia. You'll recognize that most of these patients are quite elderly, as that is the demographic we usually see it in. And these patients are presenting with minimal trauma or actually spontaneous bruising. And you can see that they really have extensive bleeding and actually drop their hemoglobins quite low just from this soft tissue bleeding. So the diagnosis is often delayed as patients initially present to physicians who have not seen acquired hemophilia before and who have not managed a case. This can lead to suboptimal treatment and bleeding complications, and that's really why we've tried in most places in Canada to create centers of expertise for this and have a referral basis set up for it. The key is to order the mixing study when you see a prolonged PTT and to look for that inhibitor. And so one thing that we always tell our trainees, but I think it should be a rule in medicine in general, is you should never let a prolonged APTT go unexplained. You should be able to explain it. And if that means ordering extra tests and identifying a lupus anticoagulant, so be it. But you should always follow it to the kind of the end of the diagnostic pathway and ensure that you have a clear explanation for each prolonged PTT that you see. So how should acquired hemophilia be treated? How should ANDRA be treated? Well, really, there's 2 pillars to treatment. The first is you want to treat the active bleeding. And the second is you want to get rid of the inhibitor. So how do we treat the active or acute bleeding? If the patient has a low titer inhibitor, so if their inhibitor titer or their Bethesda units are less than 5, giving high doses or supratherapeutic doses of factor VIII may be able to overwhelm that inhibitor. So if you give enough factor VIII, you may be able to get levels high enough that that achieves hemostasis. Often that's not the case, and it's really rare to see these patients present with low titer inhibitors. So in fact, most of the time we rely on bypassing the inhibitor, so giving a product that works its way around the need for factor VIII. So either that bypassing agent can be recombinant activated 7, also known as niastase, or a factor VIII bypassing, factor VIII inhibitor bypassing agent, such as FIBA, which is an activated prothrombin complex. It has activated 2 in it, and that's how it bypasses in the need for factor VIII in the coagulation cascade. So you can use one of these products. In some centers, depending on what your blood bank carries, you may also have access to porcine factor VIII. So here the theory is that the inhibitor you have against human factor VIII won't cross-react with porcine factor VIII. And so you can use it in therapeutic doses and actually monitor it through our assays and see that you're appropriately increasing the patient's factor VIII levels with replacing the porcine VIII or giving them porcine VIII. The thing to be careful there is that patients can sometimes have inhibitors that cross-react with the porcine VIII. And if they don't, they can actually develop them while you're giving the porcine VIII. So locally and nationally, actually, the practice is to monitor for inhibitors specific to the porcine VIII if you do use this product. So pausing again for a polling question, what is your comfort level with ordering blood concentrates? And again, please rate your comfort on a scale of 1 to 5, 5 being very uncomfortable and, 1 being very uncomfortable and 5 being very comfortable. Awesome. I'm not surprised to see this, and just to emphasize, ordering blood concentrates for the replacement of deficient factor levels in congenital hemophilia, for example, or in the context of acquired hemophilia is not something that comes up commonly. It's not something that we train our residents very well in the general medical community, and even within hematology, a lot of hematologists don't do this on a routine basis. So I would not expect most physicians to feel comfortable ordering blood concentrates because it's simply not something we do routinely outside of being a bleeding disorder physician. I will get to some resources that you can use for ordering factor concentrates in just a moment. Going back to our patient Andrea, we've treated her bleed with, in this case, we treated her with niastase, the recombinant 7A product, until we made sure that her ecchymosis, that her extensive soft tissue bleed in her calf had settled down. While we're doing that, we're also thinking about eradication of the inhibitor. So as long as the inhibitor remains present, we know that the risk of serious bleeding exists. We want to get rid of the inhibitor, and we do that by using immunosuppressive therapies. For the longest time, cyclophosphamide and steroids were the mainstay of treatment. But what we found was because a lot of our patients are quite elderly, have comorbidities, that this was actually quite a morbid therapy to give. There were a lot of complications, opportunistic infections with the cyclophosphamide steroid combination. More and more here in Calgary and across the country, we're moving to a combination of steroids and actually using rituximab upfront. Most inhibitors do respond well to immunosuppression therapy. Therefore, other cytotoxic agents that we have in our back pocket, such as cyclosporin or azathioprine, are rarely actually required. And in the last decade of practice, I can't think of one time when I've had to use anything beyond steroids and cyclophosphamide plus or minus rituximab. So that's all I will say about acquired hemophilia. I did want to mention in the context of our current pandemic, what we're seeing as far as acquired hemophilia A with respect to COVID co-infections. We know that COVID has been associated with a lot of other immune manifestations, flares of ITP, for example, or hemolytic anemia, as far as what you can see from a hematology perspective. Looking at the literature, and this literature review was done, I think a month or two ago, there have been 4 case reports reports of COVID-19 and acquired hemophilia. The demographics were the typical more elderly patient. 3 of them actually presented with more recent infection and the inhibitor, whereas the last one here, the 73-year-old male presented with a remote infection. So the infection had occurred 4 months prior. All of them had kind of the typical panel for acquired hemophilia, so factor VIII levels that were significantly decreased, kind of either undetectable or quite low at 2.2%. All of them had high titer inhibitors, and all of them were treated for eradication of the inhibitor with our typical prednisone cyclophosphamide or prednisone rituximab combinations. As far as response to treatment, it looks pretty on par with what we would expect, which is that once you start immunosuppression, we often see the inhibitor titer starting to respond quite quickly, coming down, and within a couple of months, usually we can titrate off the steroids and taper off and just follow the patient for recurrence. Now, there's a lot of concerns with respect to the COVID-19 vaccines and immune phenomenon that occur. Certainly, when you look at the WHO Global Pharmacovigilance Database, which was last updated in May when I read through it, there were 11 cases of acquired hemophilia A that were reported and thought to be in association with the vaccines. Acquired hemophilia A developed at a median of 26 days after vaccination. And again, the treatment approach is the same as far as both treating of active bleeding and eradication of the inhibitor. So that is it for case 1 for Andrea. Are there any questions at this time?
That's wonderful, Dr. Ridz. A really great overview. Yes, a couple of questions have come in. I mean, it seems like making the diagnosis is contingent on getting the PTT. We don't get the PTT as much as we used to. Sometimes our coagulation orders are restricted to the prothrombin and the INR. Is that a concern, I guess, is the question, or I guess it's just I guess it's a question of whether this would obviously potentially lead to misses.
Yeah, for sure, and it for sure can. I'm surprised to hear that. If someone could provide clarification on kind of what the threshold is for ordering a PTT, I'd love to hear it. But we know that, so the INR is really a test that was developed just to monitor for warfarin coagulopathy, right? It's not a great assay screening for bleeding disorders in patients who are not otherwise on anticoagulation. It really is in isolation only good at picking up factor VII deficiencies. So if you read kind of through the literature as far as, assessing for perioperative risk of excessive bleeding, an isolated INR is actually very seldomly helpful. And so certainly in the context of a patient presenting to the emergency department, I would suggest that just doing an INR, if you're thinking about bleeding, just doing an INR is probably not adequate. And I would do a PTT. PTTs are the assays that are going to identify the more common factor deficiencies, so mild 8, mild 9, and 11 deficiency. They're the ones who are going to identify the most common acquired factor inhibitor, which is factor 8. So I'd be surprised if it was really well, I don't understand the context, but I would push for the availability of a PTT because I do think it's an important part of a coagulation assessment in a patient.
Great, thank you. A couple more quick questions. One is whether the lab might just automatically run a mixing test when encountering a prolonged PTT, if they know the patient's not on anticoagulation, or does it always have, is it generally has to be ordered?
It generally has to be ordered. I think knowing kind of the lab setup in most places and the many reasons why people can have PTTs and most of them in an in-hospital setting, in the context of anticoagulation, now the outpatient setting, even the DOACs, I don't think most labs would run the mixing study unless they were told or asked to do so. It is quite labor intensive. I, for the purposes of demonstration, just talked about mixing and repeating a PTT, but actually it requires mixing and incubation because these inhibitors are time and temperature sensitive. So you actually have to mix them and then incubate and redo the testing again after a period of time. So they are a little bit more labor intensive than just quickly doing another PTT. So you really do have to have that index of suspicion, recognize that it is an abnormal PTT in your patient's context and order it. Now, what your lab does from there is really dependent on where you are in the country and what the lab setup is. as I mentioned, in Calgary, if as an emerge doc you go into the hemostasis panel and say, please work up prolonged PTT, the lab will take that and run with it until they have an answer. So they will do the mixing study, the lupus anticoagulant assay, and then the factor levels, and come back with a special coag physician who will give you an interpretation of what's going on. But in a lot of other centers, you actually have to order each and every single test individually. And so you really need to know what your center requires of you to be able to know how to work up these patients and what is involved in your requisition kind of requests.
Two more related questions. What PTT level would prompt you to order a mixing study? Like sometimes we'll just see a few seconds of prolongation.
Yeah.
Would that be warranted in a patient who's got like minimal bleeding? And I guess there's also another related question on how long it takes to run a mixing study and getting that factor VIII level.
Yeah, so you're right. If our upper limit of normal is 38 seconds and someone came back with a PTT of 40 seconds, I probably wouldn't think too much of it and I would just repeat it. The PTTs that tend to have really that are minimally elevated sometimes can be lab error or collection error, so kind of pre-analytic variables can factor into that. Really mild deficiencies can contribute to that. And then non-specific inhibitors can also contribute to those PTTs. So as long as the patient is clinically well and it's mild, I'd probably just repeat it. So that was the first question. The second was, what's the turnaround time for a mixing study? Again, it depends on where you are. If you know that you need a mixing study and if someone is actually looking quite unwell, I would make the effort to call the laboratory and let them know that you need it ASAP. Because in a lot of centers, this isn't a test that's being done all the time, which means that it could be batched and done the next day, or it could be done that day and not reported out until a pathologist looks at it and writes out the report, in which case you as an emergency physician are waiting on an unstable patient for an inappropriately long time. Theoretically, a mixing study can be pretty quickly done, but it's a matter of getting the blood to the right subspecialty laboratory and actually getting those people to run it and report back to you. Those are where the delays actually occur. So again, I think here, knowing that you want a PTT in an unstable patient means that you're probably calling around and letting people know that you want it ASAP. If, on the other hand, the patient is stable and you're just working up a prolonged PTT, you can probably send it off and not worry about the turnaround time, obviously.
Great. Well, last question. Oliver wants to know, because I know you've got a couple more cases to go through. Is there anything else you should order besides what we ordered for Andrea if you have non-life-threatening bleeding? I mean, one older test that comes to mind, I don't know if it's still done, is the bleeding time.
Yeah. So the bleeding time is not something that's done well in the emergency department. The bleeding time is literally a little nick that occurs in the skin, and then it's blotted until it stops bleeding, and then you mark that down. It was a test that they used to use looking for kind of evidence of a primary hemostasis defect, so platelet defects and things like that. We don't use it very much anymore because it's not specific, it's not very sensitive, it's labor intensive, and so we don't. Some of your centers may have access to a PFA, a platelet function analyzer, which was supposed to replace the bleeding time. That's literally an assay where you take whole blood and it is aspirated up a very small capillary that's either coated with collagen or ADP. And it's meant to pick up platelet defects and von Willebrand's disease. So again, not totally specific, but a good screening test, often used in pediatrics as well, because it takes a very little amount of blood. So some centers may have that as a screening test. It requires pretty careful interpretation. So if you do order that, I think it's worthwhile if you get a positive or a prolongation in one of those tests to actually talk it over with a hematologist. There's a lot of things that can also affect your interpretation of it. So aspirin, for example, will certainly affect your PFA results.
Great, thanks. And thanks to everybody for those great questions. I'll let you go on with your other cases.
Awesome. The other two cases are shorter. So the next one is Fatima. Fatima is a 57-year-old female with type 2B von Willebrand's disease who's presenting with 12 hours of melena, fatigue, and shortness of breath. Her past medical history is relatively unremarkable, and prior to this presentation, she really didn't have a significant bleeding phenotype. She reported some easy bruising, increased bleeding with dental work, and really she had been diagnosed with type 2B von Willebrand's disease based on family studies rather than her own significant presentation of bleeding. When you look at her von Willebrand factor levels, and again, normal is 50 to 150 for all of these levels, Her von Willebrand factor level or antigen is within normal range, and her factor VIII is within normal range. It's just her von Willebrand factor activity that's decreased at 25%. So what is von Willebrand factor? A von Willebrand factor is this large multimeric glycoprotein that carries two functions in hemostasis. The first is that it mediates platelet adhesion to injured endothelium. So when you have injured endothelium, it exposes your collagen. Von Willebrand factor binds to that and is unraveled by the shear flow of blood. That exposes its platelet binding sites, and platelets then bind, are able to be activated, and that initiates primary hemostasis. The second function von Willebrand factor has is that it stabilizes factor VIII. So at its factor VIII binding site, it carries around factor VIII and protects it from proteolysis within the blood. If you have von Willebrand factor around, your half-life of factor VIII is about 8 to 12 hours. But if you don't have von Willebrand factor around, so for example, type 3 von Willebrand's disease patients, your factor VIII level will fall down to about 1 hour. The half-life of it, will fall down to about 1 hour. So you can imagine that your factor VIII levels will be quite decreased if you don't have sufficient von Willebrand factor levels around. So von Willebrand's disease is the most common congenital bleeding disorder with a symptomatic prevalence of about 1 in 1,000. The bleeding symptoms can really vary depending on severity and type of von Willebrand's disease. And the vast majority of patients have mild von Willebrand's disease and really have common and mild mucocutaneous symptoms such as menorrhagia, epistaxis, GI bleeding. Bleeding can also occur with invasive procedures such as dental extraction, surgery, and childbirth. The first line testing for von Willebrand factor, or von Willebrand's disease, is to look at the level of von Willebrand factor, the activity, and the factor VIII. So von Willebrand factor level normals are 0.5 to 1.5 international units per mil, but often we describe this as 50 to 150%, and similarly for the activity and for that factor VIII. I'm not going to get into the subtypes of von Willebrand's disease very much, just enough to say that there are 3 types of von Willebrand's disease. The first is a quantitative defect. You simply haven't made enough of von Willebrand's disease. And this is by far the most common. People have mild deficiencies. This type 1 von Willebrand's disease makes up about 70% of von Willebrand's disease. The next is type 2, where you have a qualitative defect. So your von Willebrand factor is not functioning properly. There's a mutation either in its ability to form a multimer, which is important for its function, or a mutation in its ability to bind platelets or collagen. And the third is really you don't make any von Willebrand factor, so you have a complete absence of von Willebrand factor. This makes up less than 1% of von Willebrand's disease, and these are the patients who are more on the severe spectrum of bleeding. So our patient has type 2B von Willebrand's disease, which interestingly is a gain of function mutation, wherein her platelet binding site can spontaneously bind platelets, her platelet binding site on von Willebrand factor can spontaneously bind platelets. Now, a common question to me is, wait a second, you have a coagulation factor, it has a gain of function mutation. Why is this not causing a clotting disorder rather than a bleeding disorder? Well, the reason for that is when you have this gain of function on the platelet binding site of von Willebrand factor, all of a sudden you are now able to spontaneously bind platelets. And that von Willebrand factor platelet complex actually is cleared from the circulation. And so rather than having a gain of function mutation causing hypercoagulability, you have now clearance of potentially both platelets and von Willebrand factor, and specifically the larger von Willebrand factor multimers that are the most hemostatically active. And that leads to a bleeding disorder. And just to emphasize the last point, because of this clearance of these complexes, type 2B von Willebrand's disease can also be associated with thrombocytopenia, large platelets, and platelet clumping on CBCs. So von Willebrand's disease is also really important for achieving a normal angiogenesis. And we know that when you lack von Willebrand factor, you actually have increased risk for developing angiodysplasia and ultimately GI bleeding. The GI bleeding is often in the small bowel, and it can be difficult to visualize, to diagnose, and to treat. So this is what Fatima was presenting with. She was presenting with upper GI bleeding from the small bowel. She had ongoing melena in the emergency department. She was hypotensive and tachycardic. She was being appropriately resuscitated with fluids, packed red blood cells, IV Pantaloc, and GI referral had been ordered. Now, whenever we have a bleeding disorder patient with a presentation of GI bleeding, we always emphasize that to achieve hemostasis, you have to approach it two ways. You have to actually get control of the source of bleeding. So definitely encouraging GI to have a look and try to see if they can see where she's bleeding from. But you also actually want to normalize their hemostasis. You want to increase whatever factor they're missing. So rule of thumb for any bleeding disorder, but here in particular, we're talking about von Willebrand's disease, is to replace the factor for which the patient is deficient. So in von Willebrand's disease, we really want to replace the von Willebrand factor. Now, how do you do that? In some patients, we know that giving them DDAVP will release their own endogenous stores, and that in itself will increase their plasma levels to normal ranges. And so in patients who have, for example, type 1 von Willebrand's disease, or some subtypes of type 2 von Willebrand's disease, we can use DDAVP. It can be given either IV, sub-Q, or on occasion if you have access to it intranasally. But the important thing to remember about DDAVP is not everyone with von Willebrand's disease responds to it. So in an emergency setting, rather than trying to figure out whether this patient is a responder or not, unless it's clearly documented that they are responders, I would actually prompt you to not worry about DDAVP, but actually replace them with von Willebrand factor. In Canada, where we have access to 2 von Willebrand factor concentrates, Hum8P and Will8. Will8 is relatively new as far as the product monograph saying that it's available for VWD, but has been available for the treatment of hemophilia for quite some time. Hum8P has been used in Canada for a good 30 to 40 years. Both of them are very safe products, no issues with respect to them being plasma-derived and viral infections or anything like that. Definitely, they'd be the first-line treatments in type 3 and some type 2 von Willebrand's disease. But also, if you don't know if they're a DDAVP responder, you can use it in any type of von Willebrand's disease. Von Willebrand factor concentrates are given, and all blood concentrates, in fact, are actually given as a slow IV push. So they should never be put in a mini bag and hung. The reason for that is you probably lose a lot of the product in the mini bag in the tubing, and therefore giving the patient a suboptimal dose. So we always want it to be given as an IV push. So again, just to really emphasize this, take-home message is when you have von Willebrand's disease and you're not sure about the DAVP testing, it's not clearly documented in their emergency protocol, in their notes, just go ahead and give von Willebrand factor concentrates. And I think I went over the rest of these points. So a few clinical pearls about von Willebrand's disease. If you do give DDAVP, please give it carefully. It can cause symptomatic hyponatremia and seizures, especially in young children and the elderly. Whenever we give DAVP, we do educate our patients that they need to fluid restrict to prevent the hyponatremia. And the fluid restriction is generally less than 1.5 liters over the next 24 hours. So if I have a patient who's quite unwell in the emergency department and requiring a lot in the way of fluid or resuscitation, I probably would, even if I know they're DAVP responders, I would probably avoid it because I know that I can't control that fluid restriction in that particular patient. The other thing to consider with DDAVP is that really DDAVP is releasing your own endogenous stores. So there's a tachyphylaxis that occurs, meaning that if you're giving it too frequently, their own endogenous stores don't have time to catch up with the production of Hum8 or of von Willebrand factor, and therefore you get less of a response with subsequent doses. And then finally, in most bleeding disorder patients, we often will add antifibrinolytics such as tranexamic acid as an adjunct. So in really mild bleeding symptoms, you can use it alone, or in anyone who's coming in with moderate severe bleeding, you can use it in addition to the DDAVP and or von Willebrand factor concentrate. So as I mentioned, as a general rule, you want to replace the factor concentrate that the patient is deficient for. So in this patient, she certainly got the Hum8P up front. But what you also have to remember, she has that funny subtype of von Willebrand's disease where she also has thrombocytopenia and her platelets generally sit in the 30s. So in the context of an unstable GI bleed, it would also be very appropriate to give her a dose of platelets as well. And that is Fatima. I'll pause there for any questions.
That's a great case, Dr. Ridz, and highlights how not all GI bleeds are the same. Certainly something to keep an eye for. I think in the interest of time, I'm going to let you go on to the last case.
Perfect. And so I won't go through the polling question, but I did want to just emphasize to the audience that most patients with known congenital bleeding disorders who are followed by hemophilia treatment centers should have a factor first card. So all of the hemophilia treatment centers across the country do dispense these. Here locally, for example, we actually give it to patients and renew them on an annual basis. So every single year they get a new card. The reason why I want to stress this is because this card will let you know who is the treating physician for this patient. It gives you an idea of the diagnosis, whether or not they're a DDAVP responder. But more importantly, we have been in the context of the clinic of not kind of having an emergency or being rushed, have thought very carefully about how this patient should be treated, both in the context of a minor bleed and in the context of a major bleed. So the purpose of this is to really streamline the care. If they're presenting with a bleeding issue and they have a factor first card, please refer to this, because this is our way of trying to make sure that the patient gets their factor as quickly as possible. Normalize their hemostasis, then deal with source control. And so most patients who are followed by a hemophilia treatment center should have this. In addition to this, here in Calgary, and other health districts probably have this as well, we actually have embedded in both NetCare and SCM, the factor first card is actually impregnated into our electronic medical system, medical records. So again, we'll have documentation of the patient's disorder or diagnosis, what to look out for, and how to treat them if they have mild or moderate bleeding. Most of these bleeding protocols also include a note saying, if you're seeing them and you're treating them for bleeding, please call us, because often that single dose will not be enough, and we will follow up afterwards to continue with treating them as outpatients as appropriate. So another point about ordering factor concentrates, it's not common that these concentrates are ordered outside of a hemophilia treatment center. And so it can be quite daunting depending on your electronic medical system or what order system you use at your local hospital to know what you have available, what factor to use, and what dosing to use. If the patient can tell you what they usually use, it's quite easy to actually look up the product monograph, and they'll give you gross dosing recommendations there. Up to Date is also obviously a really good and quick, easy resource. But one thing I wanted to stress to you is locally, Dr. Poon, one of my senior colleagues, actually worked with CBS years ago in their clinical guide to transfusion to write up 2 chapters that specifically talk about the different concentrates that are available in CBS and how to dose them, what to look out for. The reason why I put this here is because if you can remember CBS clinical guide to transfusion and you Google that, this resource will come up. And the 2 chapters that have to do with factor concentrates are chapters 5 and 17. And then finally, in red, I've put hematology. I really would like you to consider low threshold for calling hematology. It's not unusual for me to get calls from surgeons, for example, or anesthesiologists to help them order factor and actually sit there and order the factor for them, because it is a bit of a funny thing to order through at least our electronic medical system here. This is just a table out of chapter 17 for that clinical guide to transfusion. And I know it's a little bit hard to read, but just to stress it, it tells you what factor you're looking at, what the half-life is for that concentrate, and some really kind of gross guidelines for how to dose it. So again, I think quite useful and a quick resource if you can remember CBS clinical guide to transfusion and go from there. The last patient, how are we doing on time? Eddy, should I speak about the last patient, or should we pause for questions at this point?
We do have a question. Someone's pointing out that menorrhagia is quite a common emergency department presentation. What should clue you in, if they don't already obviously have the diagnosis? What are some of the signals that should make you think that, that there may be concomitant VWD?
Great question. So when we look at the literature, I mean, menorrhagia can be caused by so many different things, but when we look at the literature and try to decide who with menorrhagia should be tested for von Willebrand's disease, it's the patients who are presenting with menorrhagia since menarche, who have had bleeding issues from other locations as well. So not just menorrhagia, but postpartum bleeding, epistaxis, excessive bleeding with challenges such as dental work, who have required blood products for the menorrhagia or surgical interventions for the menorrhagia, whether it's DIC or hysterectomy. Overall, some kind of reviews of menorrhagia actually report that the rates of bleeding disorders in an undifferentiated population of menorrhagia patients, the prevalence can be as high as 30%. So I would suggest that if they hit any of those if they hit any of those kind of clinical or historical aspects, or if they're just severe and presenting to you over and over again, just send off a von Willebrand factor panel. That's the most common coagulation defect. And I think it's a good starting point. And then have a low threshold to send them to your local hemophilia treatment center for assessment. Because if the von Willebrand factor disease panel is normal, we will then take it further and investigate further if they indeed do have what seems like a bleeding phenotype. So bleeding in multiple domains.
Thanks, Dr. Ridz. If you could do the final case in a couple of minutes, 3 to 4 minutes.
I will, and this one I think is quite straightforward. So Alex is a 27-year-old man with Glanzmann's thrombocythemia. So I wanted to include kind of one congenital platelet defect. He has a history of epistaxis and excessive bleeding with trauma, but otherwise really had not had major bleeding issues up to this point. And unfortunately, he presented delayed with a one-day history of severe headache. He was found to have an intracranial hemorrhage with associated mass effect and urgent neurosurgical consultation being recommended. Now, what is Glanzmann's thrombocythemia? Glanzmann's thrombocythemia is a platelet abnormality. It's you have a defect in the platelet GP2B3A integrin. And specifically, this is a receptor that's important for platelet to platelet or platelet to endothelial binding. So when you have a defect here, you have a lack of platelet aggregation. For Glanzmann's thrombocythemia, the bleeding phenotype can be variable. First bleeding symptoms often are at a median age of 1, but 85% of patients by the age of 14 will have had some kind of bleeding presentation. Bleeding is often worse in childhood and often improves in adulthood. But the real concerning thing here is that it's really difficult to predict who is going to have a severe hemorrhagic event. How do you treat Glanzmann's? Well, again, you can always transfuse with whatever your defect is. So platelet transfusions can be used, especially if the patient's presenting with life-threatening bleeding. The standard risks of platelet transfusions are allergic reactions, volume overload, Trally, etc. But what you also have to be careful about and not overuse platelet transfusions is that these patients have a high rate of developing alloantibodies. So they develop alloantibodies or antibodies against HLA antigens on the donor platelets or against the actual receptor that they have mutated or absent. Unfortunately, this means that subsequent platelet transfusions may not be effective, may be quickly cleared away. If the bleeding is not severe, or if they are refractory to platelet transfusions, we often will use recombinant factor 7A, so niastase. What this does is it binds to activated platelets, activates factor 10, and results a burst of thrombin, which can enhance platelet aggregation. So you're bypassing kind of the lack of that integrin that you have either mutated or deficient. Obviously, with niastase, you have a risk of thrombosis and infusion reactions. And the dosing is the typical dosing you would use is 90 micrograms per kilogram. It has a short half-life, so often needs to be replaced or repeated every 2 hours. So this particular patient does have a clear management plan documented, and his was that he should have niastase ordered. I wanted to just describe this a little bit to you in case you see it and wonder what you're supposed to do with this in any of your patient's notes if you see this in any patient notes. So because we know that these patients develop alloantibodies, if we can predict when they need platelets, i.e. in anticipation of the surgery, we will actually HLA type them and try to get HLA matched single donor platelets to try to minimize the risk of alloimmunization happening. Now, this is not something that is going to be a useful recommendation for you in the emergency setting because obtaining HLA matched platelets is something that requires a good 5 to 7 days. Essentially, you have to know their HLA type, you have to talk to blood bank, you have to get some donor across the country who is a known match to donate platelets, and then it's specifically brought here for that particular patient. So not a practical or feasible thing to do in an emergency setting, which means that if you are going to give platelets, it's just simply 4 units of random donor platelets, so the typical platelet dose that you would give in any other situation. Again, for mild to moderate bleeds, he receives niastase, and this is just to spare him the platelet transfusions, and low threshold to call the Rare Blood and Bleeding Disorders Clinic, which is what our local hemophilia treatment center is called. So that was all I was going to say about Alex, and I'll stop there. Any other questions?
I think that's about it, Dr. Ridz, but yeah, thanks for presenting that case. Rare, but scary, and nice for you to walk us through the management and the emphasizing the importance of the care plans. So we are at the end of our time. I wanted to thank you for this great talk and lots of important tips and practical advice and resources, including the CBS guidance that you mentioned. It's in the chat window. I wanted to thank everybody who joined today, my colleagues on the Scientific Planning Committee, CAEP staff team, and all of the IT support that we got through Jeff Allen Productions. Remember, this is accredited by the College of Family Physicians of Canada and the Royal College. Complete your evaluation form to get your credits, and a certificate of attendance will be mailed out to you by CAEP, hopefully in anticipation of a time when we can meet non-virtually, like in Quebec City, hopefully in June. So consider consider joining as well. The IFEM CAEP Symposium entitled Women in Emergency Medicine Around the World. This is going to be on December 16th from 10 to 1 Eastern Standard Time. The leading international speakers will address the issues facing women in emergency medical care workers in different regions of the world and what needs to change and what you can do in your own workplace to take steps towards gender equality. For more information, visit the CAEP website. Thank you again for joining. Really appreciate all the great questions. Thank you again, Dr. Ridz,
Thank you.
and wishing you a great evening.
Good night.